Now, like to welcome our next speaker, who'll be putting her slides up any moment, and her name is Dr. Karen Ousey. I'm sure she's no stranger to you all. She's the Professor of Skin Integrity and Director of the Institute of Skin Integrity and Infection Prevention at the University of Huddersfield. And she's going to talk to us about antimicrobial resistance, a global crisis. Thank you, Karen.
So thank you all very much for inviting me to present on antimicrobial resistance, a global crisis. And this is something that's really close to my heart at the moment, because I think it's so important, especially in light of the pandemic. So by the end of this session, you'll be able to locate information about antimicrobial resistance, understand the global crisis of antimicrobial resistance, be able to identify antimicrobial stewardship, and explore the role of the multidisciplinary team in both antimicrobial resistance and antimicrobial stewardship. But before we go any further, I'd just like to think a bit about challenges of infection in wounds. We talk about wound infection a lot, and as you know, the International Wound Infection Institute, Tissue Viability Society, and a range of different areas discuss infection. However, sometimes we struggle in clinical practice to identify infection from inflammation. And this really is something to do with education. We really need to be thinking of educating our undergraduate healthcare professionals about how and when to identify infection and inflammation and what are the differences. And you can see from the slides here in front of you that infection can be really quite different. This is very much in your face infection, it's quite clear. But we can see other forms of infection that aren't quite as obvious as this. And it's also important that we teach patients and carers that a wound that's red doesn't necessarily mean it's infected. It could be in the inflammatory stage. So if they're feeling well, they haven't got any pain, there's no real heat coming from that, then it's not infection and they don't need an antibiotic or an antimicrobial dressing. And this is sometimes where some of the challenges occur with our antimicrobial resistance. And we need to think as well, what is a wound infection? What's the definition? So the International Wound Infection Institute have produced this definition. So it's the invasion of a wound by proliferating microorganisms to a level that invokes that local or systemic response. If people aren't sure about this, then please do access the International Wound Infection Institute's website, where you can download all their documents free of charge that talk a lot about infection, how to recognise and how to prevent. They also have the wound infection continuum on there that you can see on the slide as well in front of you, that gives some indication of when a wound is infected and when it's inflamed, when we should be thinking about antimicrobials, and similarly when we shouldn't be thinking about antimicrobials. So very much highlights that colonization contamination stage where vigilance is required, but we don't need to be giving antibiotics or antimicrobial wound dressings. And again, think about telling patients and carers about this as well, because they're not used to wounds like we are. So they do tend to worry if that wound looks red. But what is antimicrobial resistance? So I'm talking about it and use this terminology AMR, and it's nothing new really. The Infection Prevention Society have talked about it a lot. The Centre for Disease and Control in the US have talked about it, as has the UK government, and globally it really is a threat. And it's when organisms that cause infection evolve in ways that survive all these treatments. So it's what we've been talking about is superbugs. So we can give antibiotics, but the bacteria just says, no, I'm used to this, you're not going to kill me. And it's caused a lot over the years by misuse of medicines, poor infection control practices, and our increasing global trade and travel. Now, obviously, over the past 18 months, we haven't been traveling, and people have been very much aware of how to wash their hands, how long to wash their hands for, and when to wash their hands. So that has been a good side of the pandemic, really, that people are more aware of how to prevent infection. But still, we need to be teaching undergraduates, all healthcare professionals, and patients and carers about the importance of hand washing, one of the single most important ways of preventing infection. But going back to the global threat of antimicrobial resistance, as I say, it's not new. And there's all these documents. These are just a flavour of a few of them. That if you get a chance, just go and read the executive summary to be able to give you a really good in-depth understanding of what AMR is and the strategies we need to be implementing now to prevent a crisis occurring. So the UK government in 2014 produced a 5-year antimicrobial resistance plan, and we've got the UK AMR strategy as well, which talks about prevent infection, preserve and promote. Particularly in wound care, the Global Alliance for Infection in Surgery has lots and lots of different information on their website that again is free to download. But they've produced this document, COVID-19 Lessons for the Fight Against Antimicrobial Resistance. And the World Health Organization has taught for many years about antimicrobial resistance and how we really need to be putting strategies in place now to prevent it occurring or in fact getting any worse, because actually we're in the middle of the crisis now. And I quite like this slide because this gives us a brief history of antibiotics and the resistance. And again, just exemplifying that this isn't new. It's not something that's just happened over the past 12 or 18 months. And you can see that all the way through from pre-20th century, we've developed antibiotics and antimicrobials, but the bugs have become resistant, become very clever and been able to combat what we're doing. And sadly, this is just getting worse as we go along. And if we don't act now, by 2050, there's going to be 10 million excess deaths caused as a result of antimicrobial resistance. And that 10 million deaths are more than the deaths we're going to get by cancer. So you can see why it is essential that we all understand this and that it underpins our daily practice, whether or not we work with wounds or in another specialist area. And we should really be concerned, particularly when it comes to antibiotics, in that we've had no new antibiotics developed in the last 30 years. Work is underway, research is underway at the moment, but currently we're relying on very old antibiotics. And again, this is why I keep saying we have to educate our patients and carers about efficacious use of antibiotics and indeed antimicrobials. And when I talk about antimicrobials, it's really an umbrella term that incorporates effective use of antibiotics, antifungals, antiseptics, and antimicrobial wound dressings. So it is this big umbrella term that brings all that in. And wounds, as we know, are a source of infection. And this is why AMR and AMS practices are so important. And again, you can see here, the World Health Organization has very much been trying to get that message out there of preventing a worsening AMR crisis. And when we look at antibiotic use in wound care, many of us would like to think that we don't overuse them. But guest study that was published in the BMJ identifies that each year, 50% of all wounds in the community have had at least one course of antibiotics prescribed. And that's huge. And we know that as the population ages, people have more comorbidities. We've got an increasing issue with obesity, that we're going to see more wounds that will require antibiotics and antimicrobials. So again, the importance of effective assessment and effective implementation of antimicrobials is essential. So one of the strategies is antimicrobial stewardship. You will have all heard about antibiotic guardianship. Well, it's very similar to that. But again, remember, antimicrobials covers antibiotics, antiseptics, antifungals. So this is moving it on one step, really. And it's defined as an organizational or healthcare system-wide approach to promoting and monitoring judicious use of antimicrobials to preserve their future effectiveness. And just take a moment to have a quick look at that to note that it says organization healthcare wide system. So again, what we're saying is it's everybody's responsibility across health and social care. So it's not just about a patient that may have a wound, but it's about patients who have wounds who are in the community, in nursing homes or care homes, as well as being in acute care. And who's responsible? Well, it's everybody's responsibility. It's a multimodal attack, really, to try and prevent AMR occurring. So anybody that deals with any type of patient should be aware of antimicrobial stewardship. So your physiotherapists, podiatrists, paramedics, medical staff, even receptionists at your doctor's surgeries or within the hospitals need to be aware of it. So it can be very much aware of which antibiotics and antimicrobials are being prescribed and given out. It should also be your healthcare or your organisation's responsibility as well to have some policy or guidance in place to help educate people and to guide them as to when we can and when we can't prescribe. But please remember, if a wound is infected, then it will need an antibiotic or an antimicrobial. So please don't go away from here thinking, oh, I can't give any antimicrobials. We can, but it's about effective and appropriate assessment that allows us to have a diagnosis that's very clear and accurate afterwards. So what can we do? Well, we need to provide education training to health and social care practitioners about antimicrobial resistance and antimicrobial stewardship. And as an academic, this is something I really need to be thinking about. How do we get it into undergraduate curricula? Similarly, how do we ensure that as we move into post-registration, postgraduate education, that we keep maintaining this throughout it, because it will change and we'll get new antibiotics or new antimicrobials that we can use. But we also need to be aware about the evidence and the research supporting the use of them to ensure that they are effective. We must ensure we integrate audit into existing quality improvement programs as well. So once we've implemented an antimicrobial stewardship policy, we then need to audit it to see how well it's working. So are we seeing a decrease in the use of antimicrobials and a decrease in the amount of infections? Or are we seeing an increase in the use and an increase in infections? So whenever we implement something, we must measure the outcomes of it. And we need some really good IT or decision-making support systems as well, because as I say, it is everybody's responsibility. Therefore, we need to ensure that everybody is able to get that education and knowledge as well. And we know that there's lots of new antimicrobials that come onto the market regularly. And you'll see lots of reps and different people coming into your clinical areas saying, we've got this great wound dressing, for example. But when you're considering using a new antimicrobial, do you need it? What's the research and the evidence supporting it? And is it appropriate for your patient group? Which population are you thinking about using it on? What's the dose and the dose frequency? Because we've got to think about cost effectiveness as well, and the time taken to implement any sort of change. If it's going to be restricted, who will have that decision whether or not you can use it, and how will it be monitored? And probably most importantly, is there any urgent clinical need for a new antimicrobial, which is why research and evidence is so important as well when choosing a new dressing. But we have lots of tools that can help us fight this crisis. Education is key, as I say, to all healthcare professionals across both the health and social care sector, both pre-reg and post-reg, and patients and carers. And we must work as a multidisciplinary team and involve people and professional groups such as the pharmacists. The pharmacists are key in this. They understand antimicrobials. They're able to give us advice, and they're also able to ask us, why are you still using this wound dressing? Or why are you still giving this antibiotic after 4 weeks? Have you checked the wound is still infected? Does the patient still need it? They can also give advice and education to patients and their carers as well. And sometimes we don't always make as good a use as we can of the pharmacists. We have them in hospitals, we have them in communities. And often patients who are going for their antibiotics or their prescriptions know that local pharmacist, and they feel quite at ease to talk to them about these things. So they are a really good source of information. We need local guides that incorporate both pathogen-specific antimicrobial therapy and surgical prophylaxis. But we must ensure that we have proper end dates for antibiotics and antimicrobials so that we know when to reevaluate. And then people don't slip through the net and end up having these therapies for months and months on end. There is a best practice document that people can refer to as well that was published by Wounds UK that has quite a nice pathway here for people to look at. I know it's a little bit small, but you're able to access it free online from the Wounds UK website. But it does make you think about what am I looking at before I start prescribing antimicrobials. So if infection is suspected, then appropriate microbiological investigation should be used to identify the cause. Remember, consider non-medicated dressings for infection management as well as the medicated ones, because they use a physical mode of action that can help reduce bacterial load. Involve patients, and remember, we have to educate at undergraduate and postgraduate level. This is an ongoing situation. Link nurses as well, link podiatrists, link pharmacists. They should all be involved in their updates as well. Antimicrobial stewardship as well is the responsibility of all the multidisciplinary team. And this can sometimes be quite hard to get across to teams that it's everyone's responsibility, not just the person who is looking after the wound as a priority. And consider getting programs implemented in practice, such as antimicrobial guardians, as we have antibiotic guardians as well. And remember, any change at all, we must measure the outcomes. If we implement a change, we need to know what effect it's having at the other end. And we must also feed back to everyone that's been involved in it, so they know what's going on. And they also feel valued, rather than just saying, please do this, and then never reporting back what's actually happened at the end. This is the best practice document I was talking about that's free to download. But also I'd like to point you to this paper. This is the position document that was written by Ben Lipsky and his team in association with the European Wound Management Association and the British Society for Antimicrobial Chemotherapy. And this is a position paper about antimicrobial stewardship in wound management. So definitely worth having a look at. And if people are really excited now about antimicrobial stewardship, which I'm sure you all are, there's a free online course that anybody can access on the Future Learn website. The link is here, and you're able to use this as your CPD. It is all free and will take roughly about 9 hours to complete. So thank you all for listening. I'll hand back to Tina and welcome any questions later on. Thanks, Tina.
Thank you so much, Karen. So our next speaker I'd like to welcome, as she gets her slides in order, is Gill Norman. And Gill Norman is a research fellow at School of Nursing, Midwifery and Social Work at the University of Manchester. And she's going to be speaking today about bacterial bioburden and healing in complex wounds, a prognostic systematic review. So thank you, Gill, for that tongue twister. We'll see you now, I think.
Thank you for the invitation to speak today. I'm Gill Norman from the University of Manchester, and I'm delighted to present the results of a recent systematic review of microbiological factors as potential prognostic factors in the healing of complex wounds. The next slide is our conflicts of interest statement. The work was funded by the NIHR through the Manchester Biomedical Research Centre, and the views expressed are ours and not necessarily those of the NIHR or the Department of Health. None of the authors of this work have any conflicts of interest to declare. So, our background and objectives. All open wounds contain bacteria, but this was the first systematic prognosis review to investigate whether aspects of this wound microbiome are independently prognostic, that is, predictive for subsequent healing in complex wounds. And by complex wounds, we mean wounds such as pressure ulcers, venous leg ulcers, open surgical wounds, or foot ulcers and diabetes. Finding a predictive relationship might not indicate that there's a causal relationship with healing, but it might allow better identification of wounds which are more likely to experience poor healing going forward. So that's the context for our work. Now, we use standard systematic review methods, including pre-registering our protocol on Prospero so that it's available for anyone to have a look at and compare to what we actually did in the review. Systematic searching of multiple databases, and we used systematic methods to avoid bias and error at every stage, such as using 2 reviewers, adapters to undertake screening and data extraction and checking and risk of bias assessment. We assessed the risk of bias and the quality evidence using QUIPS, which is a tool designed to assess risk of bias in prognostic studies, and GRADE, which allows us to consider risk of bias alongside other factors and produce a rating of how certain we are about the evidence that we find. Our inclusion criteria were broad, as you can see, for wound types, looking at all of the complex wounds that I previously mentioned, foot ulcers, venous or mixed etiology leg ulcers, pressure ulcers that were stage 2 or above, so open wounds, and open surgical wounds, sometimes referred to as surgical wounds healing by secondary intention. So not stapled or stitched together. Again, our potential prognostic factors were very broad. At the top is wound infection, but we also looked at numerous other measures, such as measures of bioburden, diversity, the number of types of bacteria or species in the wound, broad groups of bacteria such as gram-positive or gram-negative, or bacteria which flourish in anaerobic environments with no or little oxygen, and bacteria with characteristics that will be familiar to many of you, such as multi-drug resistance. And we also looked for studies which looked at response to treatment as a predictive factor. Our study design, in contrast, was quite narrow. We wanted longitudinal studies which aimed to measure the association of one or more of these factors with subsequent wound healing, while controlling for one or more other factors. We accepted retrospective as well as prospective design studies, but they had to be longitudinal. And our outcome was wound healing, which we assessed as either time to wound healing through a survival analysis, or the proportion of wounds which were healed at a specific time point defined by the authors. So in some senses, this is a broad review, and in other senses, it's quite narrow. What did we find? Well, we identified what appeared to be quite a substantial evidence base. If you look at the numbers on this slide overall, there are a lot of participants, a lot of people taking part in this research. However, most of the people in these studies, as you could see, are concentrated in the column under mixed infection status. And most of those people came from registry data cohorts, which, as you'll see going forward, were not well reported. And these are also studies which only looked at the impact of infection. So the evidence base is very concentrated around that particular factor. And as you'll see, it becomes sparser as we look at other factors. And you can see from the gaps in this table that there were some types of wounds, such as infected or not infected cohorts of pressure ulcers or open surgical wounds, where there was no evidence. There's no evidence in infected venous leg ulcers, for example. So take those limitations in mind as we move forward through the presentation, that what looks like a substantial evidence base actually may not be as informative as we might have hoped. Evidence quality. So we've thought about the quantity of evidence, and as I've already mentioned, there are quality issues around this. So the risk of bias, most participants were in studies at high risk of bias, and in fact only 2 relatively small cohorts had a low risk of bias. For most potential factors, except, as I've said, infection, there were low numbers of participants, which affects the preciseness of any estimate of effect in an association. Indirectness. Now, by this we mean not measuring exactly what we hoped to measure in the review. And this impacted an otherwise strong cohort because their baseline infection was not just baseline infection. Publication bias. This is the tendency for there to be studies which find positive results are more likely to be published in higher profile journals, and studies which find no effect or find a negative association may never be published, or there's a bigger delay to publication, or they're published in less accessible places. And we know there's a really high risk of this in prognosis research generally, although we didn't find specific evidence of it here. So let's hold all these factors in mind, and those are what is feeding into my statements that evidence for most associations is low or very low certainty. It's based on a combination, usually of risk of bias with imprecision, but also bearing in mind those other factors. So this slide looks very busy, but what I want you to focus on is largely the colours, that there's a lot of red and there's a lot of yellow and there's a lot of greyed out cells, and there's only a very small amount of green for looking at one cohort of people with open surgical wounds. So over here on the left-hand side of the slide, we see large numbers of cohorts, large numbers of people, which is what you would expect from my slide showing the numbers of people that we've in studies that we found overall. However, as we move right across the slide, we see this evidence starting to fall away as we look at was the data fully reported with an estimate of effect, or was there only a p-value, and then falling away again as we look at the numbers in studies which actually had a fully reported adjusted analysis for the prognostic factor of infection, and that is tiny in comparison to the amount of data overall. And on the far right, you can see gradings, which are how certain we are about the evidence. And this is low for foot ulcers and diabetes, and moderate for open surgical wounds, but very low where we only have the registry data for venous leg ulcers and pressure ulcers. And overall, across all types of wounds, we considered that it was low certainty, which means there may be an association, but that further research is likely to change the picture. Moving on, these were the studies which actually reported an adjusted analysis, including infection. So as you can see, we have surgical wounds healing by secondary intention at the top, and then we have 3 cohorts in foot ulcers and diabetes, where the top one was at moderate risk of bias, and the bottom 2 were at high risk of bias. Only the surgical wounds healing by secondary intention have a study reporting data fully with a low risk of bias. However, as you can see, all of these studies show an effect for an association between baseline infection and subsequent poor healing, or poorer healing. And that is actually in line with the less well reported, lower quality, higher risk of bias studies, which didn't report complete analyses. So the evidence picture is consistent, but obviously limited in the way in which it was reported and presented, and which we were able to analyse. Moving on from infection to the other factors that we were able to look at, we looked at a range of what I would call group level factors, such as bacterial load assessed by colony forming units, bacterial diversity, the range of species and families and genera in a wound, whether there were resistant organisms present, pathogens, it's defined by study authors, and then anaerobic and gram-positive and gram-negative bacteria. And the main takeaway from this slide is the very large number of greyed out cells where there was just no evidence. Looking at the wound types, which are divided first by the etiology of the wound and then by the infection status, we can see that there's very little evidence in most of these wound types. And where we do have a cell filled in, the writing is in red, indicating that the study was at high risk of bias, or in yellow, indicating that there was a moderate risk of bias. And again, you can see a very small number of green entries indicating cohorts at low risk of bias for only bacterial diversity and anaerobic bacteria in venous leg ulcers. We simply did not have that that low risk of bias, clear evidence for all other associations. And for many associations, there was simply no evidence. The story here is of evidence gaps. Now, we did find that there was actually no clear association with healing for any of these factors where there was evidence. So there is a lot of uncertainty around that because of the quality of the evidence and the imprecision that comes from these small numbers of people represented in these studies. 84 people here. I think the largest cohort size is 299, which in comparison with the registry data with thousands of people is very small. So we have a lot of imprecision, which produced wide confidence intervals and uncertainty. We also looked at individual families and species of microorganisms and the association with wound healing. It probably isn't surprising that the most commonly assessed were known pathogens such as Staphylococcus aureus, Streptococcus, various subspecies of that, and Pseudomonas, again, various subspecies of that. And here we found that properly fully reported adjusted effect estimates were only available for people with foot ulcers and diabetes. And across all the evidence, it was all low certainty evidence or very low certainty evidence for no clear association with healing again. And that is driven by the risks of bias and the imprecision that we've talked about affecting other factors as well. And other species or species groups were assessed by single cohorts and followed that picture of there being no clear association. And this is all fully reported in the full publication and the appendices to that if you are interested and want to look further. So in summary, most of the evidence relates to infection. Most participants are in studies at high risk of bias and where there was not full reporting. We did find that baseline of infection may be associated with less likelihood of wound healing in foot ulcers and diabetes, and probably associated with slower healing in open surgical wounds, but evidence in other wounds, such as venous leg ulcers and pressure ulcers, is more limited. Evidence for most other associations, such as bioburden and diversity and particular types of bacteria, is limited and it shows no clear relationship with healing. However, because of the low certainty of the findings, further research is very likely to change the evidence base for these associations. So what are our implications for research and practice going forward? Well, clearly taking steps to prevent wound infection and treating existing infections remains important. And further exploration of the association between infection and healing is also important to attempt to explore exactly what the mechanism is, whether the infection is perhaps a sign of poor wound status rather than in fact the actual cause of the poorer healing, or whether it does in fact have a causal role in that poorer healing. Our findings do seem to be in line with guidance that suggests restricting use of many antimicrobial dressings to wounds with clinical infection, because we didn't find an evidence base to support non-clinical infection microbiome factors being associated with poorer subsequent healing. But we do clearly need further high-quality longitudinal studies to explore associations between aspects of wound microbiology and healing. And these should be well conducted, fully reported, prospective ideally, and include full measures to try and adjust for multiple factors being involved. So I'd just like to close by thanking all my co-authors, Chinushi, Maggie Westby, Bianca Price, Andrew McVeigh, Joe Dunville and Nikki Kellum. I'd like to thank Sue Golder for her development and implementation of search strategies in what is a difficult area. And I'm grateful again to the NIHR through Manchester Biomedical Research Centre for funding this work. If you would like to read the paper or to look at the protocol, I've put the links on the slide here. And these are fully open access. Thank you very much for the invitation to speak today, and I hope to hear your questions later. Thank you very much.
Thank you very much, Jill. I'd like to invite you to put on your camera now and join the panel then to have some questions and answers. So if you haven't come up with any questions yet for these two, please put those in the question and answer box or in the chat box, and then we'll get going. But two brilliant questions we have so far. So I think that is inspiring. So the first question then, and I think that was for Karen. It says, really useful presentation, thank you, Karen. Are there any particular challenges with discriminating between infection and inflammation in chronic skin ulcers, where the classic clinical signs of infection may not present clearly because of the underlying condition? Thank you in advance for your advice.
Thanks, Tina, and thank you for the question. It's really difficult sometimes because there's a lot of people need more confidence sometimes to be able to differentiate between the two. However, there's some really clear guidance, again, with the International Wound Infection Institute. They've brought out a really nice table that tells you about the covert and the overt signs of infection. So it's just, remember not just to look at the wound though, to talk to your patient as well. So the wound may look red and the patient goes into full panic mode because obviously they don't normally have a wound and they don't normally see this reddened area. So ask them how they feel. Do the temperature. Ask them, do they feel hot? Do they feel tired? Do they feel sick? So it's generally asking them how they're feeling. And then have a look at the covert and overt signs that are documented by various different people, and then try and link them together. But the biggest thing is comorbidities are an issue. As we know, our patients are generally getting older and tend to be poorlier as well. So talk to the patient and ask them how they're feeling, because just by chatting to them, you can get a really good feel for, is it infection or is it inflamed? And obviously, if the wound has got lots and lots of green exudate pumping out of it, and the patient says, I feel really rubbish today, it's quite clearly infected. Have I answered that, Tina? Have I done my usual gone off on a tangent and telling a story?
No, I think you've answered that. I mean, there is a real problem, isn't there, with recognition of infection. And then you mentioned in your presentation, you know, about how we need to teach the undergraduates and make sure they have it within their training. But of course, actually, clinically, people are being trained by people that haven't got it either.
That's the issue, Tina. And I do think it's our responsibility as academics to be saying to the students as well, please go out and talk to practitioners and understand what they know as well, because it's a two-way process teaching as well.
Yeah. And as I say, it can be very difficult, but as I say, looking at the whole patient, that holistic assessment that's so elusive to many.
No, the other big thing, and I'm sorry, Jill, I'll let you get a word in edgeways in a minute, but it's teaching the GPs as well. And I think we're going to have a few issues probably over the next few months because of difficulties that people are facing actually physically getting to see the GP. So the patient describes the wound and says, oh, it's red and it hurts and I think it's infected. And they say, okay, here's a prescription for antibiotics, or get the nurse to put one of these special dressings on that will kill everything. So we're in for a rocky road at the moment until we actually get back to very clear face-to-face or some good telehealth.
Do you think that the new technology is going to be helpful there? I mean, we've now got cameras that can see, you know, by old colour, that can see, you know, the presence of bacteria, not necessarily whether they're causing an infection, but the presence. But do you think with AI and this type of technology that this may be the way forward?
Oh yeah, I think in the next few years, AI is going to really take over. And that's going to really help us because the world has changed and we're not going to go back to things we did in 2019 sometimes, but we've still got to teach the GPs as well about infection and inflammation, because I think I tend to focus on all professional groups apart from GPs in my session, but they also need support as well because they've got lots of things to look at. So we just need to remind them what's the difference.
Can I ask Connie, are you able to scroll down the chat at all to find any questions? Because I find myself unable to scroll down the chat. It won't go. So Connie out there, whether she can look down there and find some of those questions in there. I mean, all I've got is a question in there that says, is Inidine dressing considered to be a non-medicated dressing for infected wounds? Inidine. Well, Inidine is antimicrobial.
Yeah, so Inidine is a medicated dressing, but there's also a range of non-medicated dressings as well that are available, such as your Sorbax, Leucomeds, Hydrocleans. So have a look at those that actually have that physical pulling it out of the wound rather than putting something into the wound. And there's quite a few. Oh, there's a few documents round and about as well that can help people understand the difference between medicated and non-medicated, or active, non-active, whichever terminology you want to use.
Is there any questions?
Yeah.
Connie, can you see any questions?
Yeah, no, that was the end of the questions. However, I kind of wanted to add a point about patients getting face-to-face appointments with GPs. There's been a massive increase in patients coming to the independent sector because they can't get face-to-face appointments with GPs. Lots of things are getting missed. Lots of basal cells and squamous cells are coming because they've sent a picture to their GP. Their GP have given them a prescription for an antibiotic and it hasn't healed or done anything about it. So I think, oh gosh, Karen, you're 100% right, because I think that there's a massive problem facing all of us in the future. Yeah.
And Gill, is Jill still there? I can't see her. Oh yes, sorry, I can't see her on my screen. I thought you disappeared. Just a question for you, Gill, you know, about the systematic review and things. Can you see that there's going to be, you know, is there the prospect of further research coming out that will actually give us better information, really? You know, obviously the evidence from the systematic review is there really isn't any clear evidence there for us to work from.
Well, there probably is already more evidence because of the time lag involved from the search of a systematic review through to getting it published. But what I would say is that the studies that we found that were the most recent ones tended to be the ones which were conducted in a way that gave us confidence. They were reported well. They tended to have more patients, that there is funding and conduct going on based on that of studies which are better equipped to answer the types of questions that we were looking at. So we've identified a need for people to look at this going forwards. And the suggestion seems to be from the research picture that it's a developing field, would be the best way to put it, I think. So it's something to revisit, I think, that there would be an obvious purpose in updating a search, perhaps in, say, 5 years' time, to see how the evidence picture has shifted.
That's fascinating. Thank you. Thanks very much. Is there any other questions? Can you see? Sorry, I can't move the chat up and down.
Have you seen the ones in the Q&A, Tina? Have you seen the ones in the Q&A? There's one from Anonymous and one from Natasha. I'm not sure if you've covered them.
Here's your question.
Yeah.
8 plus 7
15.
plus 7
22.
plus 6
28.
plus 6.
Sorry, Leanne, have you got your thank you. Not quite sure what she was counting. Anyway, oh yes, we've got another question in there. It says, please explain again your fines reported restricting antimicrobial dressings with click infection. Why? I thought it would prevent the use of using antibiotics. I think that must be aimed at you, Karen.
Yeah, I think Leanne was probably counting all her money then. We heard her. So we're not saying don't use antimicrobials. What we're trying to say is that be aware of antimicrobial resistance and don't be using your antimicrobials this just in case scenario. So I'll pop an antimicrobial and give you some flucloxacillin just in case you might get an infection. So it's about a good assessment, exactly like you said earlier, Tina, about that holistic assessment. Then look at the wound bed and think, right, is this infected? If you need to take a swab and find out what's going on. So it's using them appropriately, effectively and timely. And then also doing clear evaluation dates. So sometimes in the past, patients have fallen through that gap of we've gone to see a patient 6 months later and they've still got a silver dressing on, for example, just because people have forgotten that the AG at the end of it means silver. So they've carried on putting it on rather than thinking, actually, I need to swap something that isn't AG. So it's correct assessment, timely assessment, regular evaluations.
Thank you. And someone, Natasha, has said, just a comment really, biofilms and chronicity of wounds is probably making more people leap to antimicrobials. Education to eliminate all factors impeding the healing is vital. I think we probably would agree with that.
Yeah, and it's we've had this debate a few times with one of my colleagues about using your antimicrobials for biofilm management, and it's quite a fine line of how do we ensure that we're managing biofilm properly without overusing antimicrobials. And again, it's got to come down to education and that people understand the bigger picture and not just think I need to manage a biofilm and not think about everything else that's happening.
Well, thank you very much. Thank you very much, Karen and Gill, for your great presentations.